Okay? For those of you who are in my ClinCore small group, we've already covered quite a bit of this. So it'll be a little bit of a review for you. Hopefully a lot of this is review for you anyway. I should have talked about urinary tract infections before you got to this point. You may or may not have heard about interstitial cystitis. It's kind of a weird thing, which is why it has its own lecture. So that being said, we'll get started. So here's your learning objective for adult urinary tract infections. Okay. So some definitions. Simple cystitis. So simple cystitis is a bladder infection. Okay. Period, full stop, right? Confined to the bladder. In order for it to be simple, then you're talking about somebody who doesn't have a fever, they don't have any systemic constitutional symptoms. Positive urine culture, dysuria, urgency frequency, that's your simple cystitis, okay? An uncomplicated UTI is cystitis in a non-pregnant premenopausal female without underlying urologic abnormalities. I am not going to ask you to define these on the exam, okay? Just know that this is how they're broken down, and that there is some clinical relevance, but there's not going to be a question that says, what's the correct definition for this term, okay? Complicated UTI. So cystitis in a patient with underlying urologic abnormalities or other significant comorbidities. And as you can see here from the little caveat, any cystitis in a male patient is by definition complicated. Men aren't supposed to get urinary tract infections. We'll talk about why that is as we get further into this. But by definition, if you see a male with a urinary tract infection, it is by definition complicated, okay? And then urosepsis. The only reason this term is on here is because you're gonna see it. It's not a real thing. What I mean by that is there's not an ICD-10 code for urosepsis, okay? If you try to diagnose somebody with urosepsis in Genesis, you're not gonna find the code anywhere because it's not a thing. So you can have somebody who has complicated cystitis and they're bacteremic and they're septic, and they have all those things, but there is no diagnosis that is urosepsis. But it is a shorthand way to describe someone who has sepsis from a urinary source. Okay? But it's not a real diagnosis. Does that make sense? Any questions? Okay. All right, so we're going to talk about cystitis, pyelonephritis, and urethritis. We've talked a little bit about pyelonephritis already, at least in terms of, white blood cell casts and that sort of thing. So hopefully this is all review for you from first semester anatomy. So what about this diagram gives you some insight into why urinary tract infections aren't supposed to happen in males?
Longer urethra.
Length of the urethra and its location. So what's the most common cause of urinary tract infections, organism-wise, in females? E. coli. Where does E. coli live? In the intestines, right? There's a pretty big gap here between the opening of the GI tract and the opening of the urinary tract, which is not the case in female anatomy. Significantly closer together. And then the length of the urethra. So the male urethra is a significant distance, especially when you compare it to the female urethra, which is about 3 centimeters. It's a whole lot easier for bacteria to migrate up the female urethra and into the bladder before they have a chance to be washed out by periodic urination, which is what happens in males. Even if bacteria gets into the male urethra, and we're talking about E. coli, we're not talking about sexually transmitted illnesses. urination is usually enough to wash them out before they have a chance to get far enough in where they can start anchoring themselves to the urothelium. Okay. So again, look at the distance here. It's significantly closer. Very, very easy. And you don't even have to take into consideration, personal hygiene, wiping technique, front to back, that sort of thing. Even with appropriate hygiene practices, it's still very, very easy for bacteria to migrate this short distance. Any questions about the anatomy as it pertains to urinary tract infections? All right, so more on intrinsic defense mechanisms. So again, we talked about the distance, we've talked about how easy it is for the bacteria to get there. And even with regular voiding, because that distance is so short, bacteria may have already had a chance to migrate all the way in and start anchoring themselves to the urothelium in the bladder. Now there is a protective glycosaminoglycan layer around the inside of the bladder that interferes with that bacterial adherence. It's believed that some patients have a deficient layer, which increases their susceptibility to urinary tract infections, which is why you can have two people who are anatomically identical and do everything the same way. They have the same toileting habits, they wipe front to back, all that stuff, and one of them has a problem with recurrent urinary tract infections and the other one doesn't. And then urine itself, at baseline, under normal circumstances, is not a particularly favorable environment for most bacteria. Urine does grow bacteria rapidly. We talk about, I think I've mentioned this before, a urine culture takes 48 hours to get final results back, organism and sensitivities. Whereas blood cultures can take significantly longer than that. They'll usually watch blood cultures for a week before they tell you that they're negative. But acidic pH, of course we know that urine can also under certain circumstances be significantly basic, but acidic pH, high urea content, high osmolality, we've talked about the effect that urine concentration has on the appearance of red blood cells under the microscope. They can be crenellated, they can look like they're dehydrated because of the osmolality difference. Same thing happens with bacteria. So, the normal periurethral flora in women provides some defense against colonization. Lactobacilli are very effective at creating an inhospitable environment for multiple organisms. This is part of the reason why if you have a female patient who's been on antibiotics for any reason, urinary tract infection or otherwise, they can end up developing a yeast infection because you disrupt this normal biome and it allows yeast to colonize and overgrow. Okay. So something to keep in mind when you're talking about putting a female patient on antibiotics for any reason. A lot of female patients know that they're susceptible to yeast infections following any course of antibiotics, and they'll tell you, hey, if I take antibiotics, I get a yeast infection. Can I get some diflucan to go along with that? Just give a dose of diflucan. It's easy. And then prostatic fluid is high in zinc, and zinc has a natural antimicrobial activity. So combine that with the length of the urethra and you've got some protective capabilities there. Short urethra. Beat that to death, right? And then pregnancy can increase risk of urinary tract infection. Can also increase risk of asymptomatic colonization of the urinary tract. And why do we care about that? Why is it important to know that pregnant women are at increased risk for urinary tract infections and for asymptomatic bacteria? If you saw a patient with asymptomatic bacteria who's pregnant, why would you treat them? What's the reason?
So it doesn't make its way to the kidneys?
Okay, so there's a chance that it could descend and they could get sicker, sure. Always a possibility. But we don't necessarily worry about asymptomatic bacteriuria in non-pregnant patients. So what's the difference?
Baby?
So it has something to do with the fetus. So asymptomatic bacteriuria has actually been shown to increase risk of premature delivery. So if you check a urine culture on a pregnant female and they're completely asymptomatic, they don't have any complaints whatsoever, and it grows a single pathologic organism, they have asymptomatic bacteriuria, it should be treated. Obviously with an antibiotic that's appropriate for somebody who's carrying a fetus. And then in males, uncircumcised males are at increased risk for urinary tract infections because bacteria like warm, moist environments, and that's what it's like underneath the foreskin. Also, anybody with prostatic obstruction. So this is why, by definition, a male urinary tract infection is complicated, because if they're older and they have BPH, then part of the reason that they may have a urinary tract infection is because they're not emptying their bladder all the way because of the enlargement of their prostate. So anytime you see an older male patient with a urinary tract infection, you need to be thinking BPH. And if they're not seeing a urologist, they need to. Now, sexual history questions can be uncomfortable. It takes practice to get comfortable with asking those questions. It takes practice getting comfortable putting your patients at ease asking these questions, but they're very important. You'll find as we get further along in the urology section that taking a complete sexual history is important for taking care of your patients and making appropriate diagnoses. So anal intercourse, regardless of your sexual orientation, increases risk of urinary tract infections. And I would also make it a risk factor in females as well. Females who engage in receptive anal intercourse are at increased risk of urinary tract infections because there's something actively moving bacteria from one place to another, okay? So ask those questions. It may also lead you down a road of determining that maybe they don't have a typical organism that you would expect to find causing urinary tract infection, especially if they're immunocompromised. So if you've got men who have sex with men, if you think about the questions you have to answer when you donate blood, then sex with men, pay for intercourse, been to Africa recently, that sort of thing. The organisms that they're more likely to have having cause infections are things that you wouldn't necessarily see in a immunocompetent person. Okay. All right, so urinary stasis. So this is a problem in pregnant women because having an extremely gravid uterus alters the orientation of the pelvic organs, and it can cause the bladder to be in a position where it doesn't empty all the way. So another reason why pregnant women are at increased risk for bacterial colonization and urinary tract infections. Older women that have pelvic organ prolapse just as a result of age. So I talked about this with my ClinCore small group. This kind of touches on another topic, but it relates to this. So does pregnancy make it more likely that a patient will have urinary incontinence, stress urinary incontinence?
No.
If you're in my small group, don't answer. The answer is no. So having had multiple pregnancies, particularly large pregnancies, vaginal delivery, makes it more likely that any stress urinary incontinence that occurs is worse, but it doesn't increase the incidence. And how do we know this? How did we figure this out? So, and we'll talk about this more in the urinary incontinence lecture, but just real quick, some smart urologists in Italy decided that they wanted to investigate this further, so they wanted to compare the general population to a population of women who hadn't even had sex before, let alone had children, which was relatively easy for them to do because there's a really high concentration of convents in Italy. So they went around to the convents and they surveyed the nuns, and then they surveyed the general population. And what they found was that in a population of nuns, and granted, you can have somebody who doesn't decide to enter the church until after they've maybe had a sexual partner or two, but by and large, the majority of the nuns that responded to the survey had never even had intercourse before, and the overall incidence of incontinence in the nun cohort was the same as in the general population. So the incidence of urinary incontinence in women is unchanged, whether they've had multiple pregnancies or not, but their incontinence can be worse. Now, how does that relate to urinary tract infections? So stress urinary incontinence is caused by urethral hypermobility and pelvic organ prolapse. So if the bladder, which sits right behind the pubic bone, right? What's behind the bladder in females?
Uterus?
Well, it doesn't get quite that high, maybe the dome, but the vaginal vault is directly behind the bladder, which is a potential space. And the only thing holding pelvic organs up, for the most part, in females, is connective tissue. It's not skeletal. In males, where the pelvis is narrower and you don't have a big birth canal, there's more solid skeletal structure holding everything up in place. But what happens to soft tissue as we age? It loses its elasticity, it becomes more lax. And as a result, the pelvic organs start to prolapse. And when the bladder falls backwards, because that's what happens when the vaginal vault is behind there, it's a potential space, so when it starts to fall backwards, now you have a trough where urine can collect, and it can't make it over that hump, if you will, to get out the urethra, and so they end up with urinary stasis. So the other places that you'll see urinary stasis are men with BPH, as we've already talked about, enlarged prostate. They can't generate enough of a bladder squeeze to push the urine out. They also develop a trough as the prostate enlarges vertically. It impinges on the floor of the bladder, and now there's a moat, and there's no way for urine to get over it. And then children with vesicoureteral reflux. Can adults have VUR? Yes, if it wasn't diagnosed when they were a child, or they've had such bad urinary retention for such a long period of time, they've actually blown out that valve mechanism that we talked about last block. But VUR is going to be more common in kids. But again, they've got urine that just keeps refluxing up the ureters, and it never empties all the way out, so it becomes colonized. Okay. Obstructive conditions at any anatomic level. So a ureteral obstruction, a urethral obstruction, say you have somebody who's had multiple bouts of gonococcal urethritis, they develop urethral stricture disease, or maybe they haven't had sexually transmitted illnesses, maybe they're like Johnny Knoxville and they ruptured their urethra doing a stunt for Jackass and haven't had a urethroplasty yet. That actually happened to him. He had to have a urethroplasty because he had a straddle injury. I can't remember if it was on a bicycle or a skateboard. But he ruptured his urethra and had to have a urethroplasty. That was before he got dropped on his head by a bull and decided he wasn't going to do stunts anymore. Diabetes, as we've talked about, foreign bodies. So anybody with a foreign body in their urinary tract is going to be colonized, especially if that foreign body leads to the outside, but it doesn't have to. So if you have somebody who has a ureteral stent in, either because they're being treated for a kidney stone or because they have an abdominal malignancy that's impinging on their ureters and keeping their kidneys from draining, you put a stent in somebody or a urethral catheter, within 48 hours they are colonized. That doesn't necessarily mean they need to be treated for it, because if you treat colonization over and over and over again, you're breeding for multi-drug resistant bacteria. Just know that their urine isn't going to be clean anymore after 48 hours. Now, if the foreign body is a completely internalized, naturally occurring object like stones, just having a kidney stone does not make you colonized with bacteria. But if you have an infection on top of the presence of a stone, then the stone can end up becoming colonized. And in those cases, you might have to get the stone out before the person's gonna stop being colonized with bacteria. So for a run-of-the-mill urinary tract infection, it's usually an ascending infection. Can it be descending? Sure, but most commonly, if you're talking about a simple cystitis, it's going to be ascending. Pyelonephritis is often ascending as well, but it is more likely than a simple cystitis to have developed from a hematologic source. And I'm not saying that hematogenic spread is the most common cause of pyelonephritis. I'm saying that if somebody has bacteremia for some reason, then if they're going to get a urinary tract infection from being bacteremic, it's more likely to occur in the kidneys than it is in the bladder. Does it make sense? So if you have somebody who's sick already and you think you've done everything you need to do to manage the original presenting problem and they're still sick, think about potentially imaging their kidneys and make sure they don't have an abscess that developed. I've seen that a handful of times. Lymphatic spread's relatively rare, and then direct extension from other organs. So I have seen some pretty wild colovesical fistulas that have formed as a result of bad diverticulitis that ruptured, developed an abscess, and then fistulized into the bladder. Okay. You call urology for that, not nephrology. And depending on where you are, it might be general surgery that manages that problem. It might be urology, it might be both. Sometimes your colorectal surgeons will take care of the bladder part of a colovesical fistula on their own and not call us. Other times they will. It just kind of depends on their level of comfort and what you have access to. All right, so here's your diagram. Ascending infection right below this line. And don't pay attention to that little segment of ureter that happens to be below the line. Cystitis. Above the line, pyelonephritis. Any questions on that? Okay, so uropathogens. We've already talked about E. coli. About 85% of urinary tract infections, by far and away the most common cause of urinary tract infections in adults. And then in your hospitalized patients, very high likelihood of developing a Pseudomonas urinary tract infection. Staph aureus is very common in catheterized patients. Okay. And then some of these other ones that you see in community-acquired UTIs are also common in the nosocomial environment as well, like Klebsiella, Proteus. Ureaplasm, ureolyticum. We'll talk more about Proteus and ureaplasm and why they're important a little bit later on. All right, so asymptomatic bacteriuria. Talked a little bit about this already. No symptoms, but positive culture. Well, there's not going to be a whole lot of situations where you're going to check a urinalysis on somebody who's asymptomatic, but for those times that you do, if they have a positive culture, then by definition they have asymptomatic bacteria. You only have to treat asymptomatic bacteria if they're pregnant or if they're getting ready to have an invasive urologic procedure. So let's pretend for a moment that you have a patient who you know is going to be having a transurethral resection of their prostate with urology at some point in the near future, and they come to see you for something unrelated. You're their primary care manager, and you check the urine and culture on them for some reason, even though they're not having symptoms, and it comes back positive. You need to treat that one. And we're going to be checking for it anyway. We check a urine culture on everybody we're getting ready to do an invasive procedure of the urinary tract for. But, you know, if you find it, go ahead and treat it. You might save the patient from being rescheduled. So, A little more detail on asymptomatic bacteriuria in pregnancy. Colony count of 100,000 colony-forming units is the same threshold that you would use to say this person has a urinary tract infection if they were symptomatic. I would argue that there are many obstetricians that will pull the trigger on antibiotics below this level, just because they're, it's relatively easy to treat. You don't want to have premature rupture membranes, premature delivery for something that you could have easily handled. So your first line treatments in pregnant patients are going to be things that are safe in pregnancy, right? So the first thing you're going to go with is amoxicillin. If you have to use Augmentin, amoxicillin, clavulanic acid, do that. The reason to preferentially pick the amoxicillin over the Augmentin is because so many people have GI upset with Augmentin. You don't want to give your pregnant patient diarrhea if you don't have to. And if they have a penicillin allergy, then you can start looking at your cephalosporins. And then macrobid should be avoided in the first trimester because it can cause issues for the fetus. Okay? So unless you absolutely have to use macrobid, don't. Okay. So you can have viral cystitis. Doesn't happen very commonly. Obviously, you have to do special cultures to test for viral cystitis. Something to take into consideration, or something to keep in the back of your mind if you're taking care of a patient who's immunocompromised for some reason, whether they have HIV that isn't well controlled, or maybe they take immunosuppressives for some reason. A common thing that you'll see in organ transplant patients who are on immunosuppressives is they can get cytomegalovirus cystitis. There won't be any questions about that on the exam. Just know that viral cystitis is a thing, and something to keep in mind when you're taking care of particular patient populations. And as we've said several times already, cystitis in men is uncommon and usually means that there's something else going on. All right, so when you see somebody with a urinary tract infection, or somebody who comes in to see you thinking they have a urinary tract infection, what are they going to be complaining of? What's their presentation? It's on the slide.
Painful, frequency, constant need to pee.
So the most common complaints are usually dysuria, frequency, and urgency. Nocturia, not so much. Or they may just not even think to mention it. But really, it hurts when I pee, I'm peeing more frequently than I normally do, I get the urge to go and it's sudden onset and I can't control it, or the urge never goes away. I always feel like I need to go to the bathroom, it never stops. Those are your common presenting symptoms. If you push on a patient's belly on physical exam, they may have suprapubic discomfort with palpation. They may not. They may or may not have hematuria, gross hematuria. On microscopic analysis, they're almost always going to have red blood cells present, but they may or may not have visible blood. Okay. If they're afebrile, even if they have visible blood, it's still a simple urinary tract infection, unless they're male or pregnant. And then symptoms can appear after having intercourse. So there are some women who are just prone to having postcoital urinary tract infections. That's one of your populations that you'll consider for suppressive therapy. If they know they're going to get a urinary tract infection every time they have sex, then you can give them prophylaxis that they can take prior to intercourse, and it'll prevent them from getting a urinary tract infection. We'll talk more about that later. Again, if they're afebrile, it's uncomplicated unless they're male or pregnant. Don't do imaging for a bladder infection, please. Any imaging, it's not necessary. If it's a simple urinary tract infection, you don't need to image them. If it's complicated, if they're febrile, if they're male. Not necessarily if they're pregnant, unless what you're talking about doing is an ultrasound, right? You don't want to expose mom and baby to ionizing radiation. And even if pyelonephritis is suspected, you don't necessarily have to do imaging off the bat to make the diagnosis. Pyelonephritis is a clinical diagnosis. Dirty urine, flank pain, fever, pyelonephritis. That's all you need to make the diagnosis. Now, if you're treating them and they're not getting better, or if they're really sick, like 103 fever, hypotensive, on top of dirty urine, flank pain, you might image them and make sure they don't have a renal abscess. Because if they have a renal abscess, you can throw antibiotics at them until the cows come home, and they're not gonna, they might get better for a while, but as soon as the antibiotics stop, they're gonna get sick again. If they have an abscess, it has to be drained. So on your analysis, you're gonna see pyuria and bacteriuria, right? White cells. If it's casts, think pyelonephritis. If it's just free-floating white cells, then, and they're afebrile, then uncomplicated UTI. The degree of pyuria and bacteriuria does not necessarily correlate with the severity of symptoms. You can have somebody who has minimal symptoms and has too numerous to count whites, too numerous to count bacteria. And conversely, you can have somebody who's really, really sick and have not very many bacteria, not very many white cells. I think we talked about this in the first lecture of the last block when we were talking about urinalysis and dipsticks and things. Can you have false positives on leukocyte esterase and nitrite?
Yes.
Yes, you can. So keep that in mind. And then always get a urine culture. Always get a urine culture. Even if it's somebody who you've been taking care of for a while and you already know that they have real, proven urinary tract infections, continue to get the culture because something can change. They could end up having a change in organism and the antibiotics that have worked for them before may not be appropriate. Also, if you've been treating them for recurrent urinary tract infections for a while, they may have developed resistance, and you need to know that. You need to know that the sensitivities have changed. So always get a urine culture before starting them on empiric treatment. All right, so differential here. I talked about this a little bit with my clinical core small group because can you have somebody who presents with urinary urgency, frequency, dysuria who doesn't have a urinary tract infection? Yes. So that's another reason to get the culture. Don't automatically assume that just because somebody has that constellation of symptoms that they have a urinary tract infection. They might have overactive bladder. Just plain old run-of-the-mill overactive bladder can present with the exact same symptoms and it does not need to be treated with antibiotics. Furthermore, they're not going to get better. They're going to continue to have the same symptoms. You're not doing anything to help them. So make sure you get a urine culture. And then we'll talk about interstitial cystitis in the next lecture. We've talked about how bladder cancer can cause irritative voiding symptoms as a presenting sign. Anybody who has a history of pelvic radiation for any reason, colon cancer, bladder cancer, prostate cancer, anything with radiation to the pelvis, they can end up with radiation cystitis, which is not infectious. It's bladder irritation from having been radiated, and they will have similar symptomatology. You can have people with psychosomatic disorders that cause them to have urinary urgency and frequency. People with high levels of anxiety often have urinary tract manifestations. And we'll talk more about these other specific infectious processes as we go forward. All right, so again, difference between complicated and uncomplicated. Pretty much everybody with an uncomplicated UTI is going to be treated as an outpatient. You never see anybody getting admitted to the hospital for cystitis. If it's complicated, that doesn't necessarily mean they need to be admitted. They might, but not necessarily. If you see a guy with BPH who has a urinary tract infection and their vitals are normal, do they need to be admitted to the hospital? No, but by definition, they have a complicated urinary tract infection, right? So just because they meet the definition of complicated does not necessarily mean that they need to be admitted. They can potentially be treated as an outpatient. Short-term antimicrobial therapy for uncomplicated cystitis. Okay, 3 to 5 days. If you treat them longer than that, you're potentially over-treating them. You're at increased risk of messing up their gut biome, causing yeast infections, things of that nature. If it's pyelonephritis, you're going to be treating them for 7 to 14 days, depending on how sick they are and how quickly they improve. I'd err on the side of caution and split the difference of 10 for pyelonephritis at a minimum. For a long time, our go-to for urinary tract infections was fluoroquinolones, because they're a very, very effective antibiotic. As a result, we have lots of organisms that have developed fluoroquinolone resistance now. So we tend to try to hold off on using fluoroquinolones as a first-line treatment anymore. We've even backed off using fluoroquinolones for pre-procedure prophylaxis in urology. When I first started training, if somebody was going to get a ureteroscopy for stones, or they were going to have just a plain old office cystoscopy, just under local anesthetic in clinic, we'd give them a dose of Cipro before we stuck a scope in them. We don't do that anymore because it has really significantly increased the rate of resistance. About the only procedure that we routinely give prophylactic fluoroquinolones for anymore is transrectal guided needle biopsy of the prostate, because you're going to be pushing bacteria into tissue going through the wall of the colon. So unless you have a culture that tells you you need to be using a fluoroquinolone, don't jump to Cipro or Levaquin as your first line agent. Macrobid is great as long as it is not pyelonephritis and the patient is immunologically normal. Why is that? What is unique about, well, I shouldn't say it's unique. There are other antibiotics that are like this too. What's different, if I told you to compare Macrobid to Cipro, what's the major difference between those two medications other than the fact that they're different classes of antibiotics? As far as mechanism of action. Is Cipro bactericidal or bacteriostatic? Bactericidal. It actually kills bacteria, right? Is Macrobid bactericidal or bacteriostatic? Bacteriostatic. It doesn't kill bacteria, it inhibits replication. So it doesn't get rid of the bacteria that are there, it just stops them from multiplying. So if you have somebody who, and the other thing is, Macrobid has 0 tissue penetrance. 0. None. Do you think it's a good choice for pyelonephritis?
No.
It's not. Have I seen people prescribe Macrobid for pyelonephritis? Yes. And then they consulted urology and we said, we need to change these antibiotics. So don't use it for pyelo. I wouldn't recommend using it for complicated cystitis because there's other things going on. A bacteriostatic agent is not necessarily going to solve the problem. But if there's not a contraindication to using Macrobid, use it. It works really well in your anatomically normal, physiologically, immunologically normal patients. Now, who's heard of fosfomycin before? Anybody? Heard it before today? So fosfomycin is actually a much older antibiotic. It's been around for a really, really, really long time, and it just sort of fell out of vogue because there were better things that came around. And as a result of that, the current populations of bacteria don't have much resistance to fosfomycin. So it has really become a much more popular antibiotic for treating urinary tract infections. It's also super convenient because it's just a single dose. It's 3 grams, 1 dose. Simple cystitis. And you can use it empirically. So while you're waiting for that culture to come back, you can give a patient a dose of fosfomycin and you may have solved their problem. Okay. This is an example of what a urine culture result looks like if you've never seen one before. So specimen information is at the top, and then here it tells you what the organism that grew out from the culture was. So in this case, we were looking at Staph aureus, and it is methicillin resistant, so it's MRSA. And then it tells you what antibiotics they tested it against, and then its sensitivity. So R means what? Resistant. S means susceptible, right. But something you have to look at is the MIC concentration. On this one it says MIC dilution, but in other reports you'll see concentration. All right, so not only is this resistant to Bactrim, it's really resistant to Bactrim. So concentrations of greater than 320 and it was still just plugging along. All right, so even if it says sensitive, take a look over here and make sure that the concentrations necessary to reach effective end results on the bacteria aren't wildly high, because sometimes you'll be surprised. But that's how you go about picking what antibiotic you're going to use or change to if you started the patient on something empiric. And you see here vancomycin at the bottom, susceptible. So if we scrolled further over on this, we would see what the dilution sensitivity concentration is. All right, pyridium we've talked about before. As you can see from this picture, this explains why pyridium causes a false positive on dipstick for nitrites, because that's what it looks like, and that's the color of the box when it changes. So always be sure to ask patients if they've taken over-the-counter azo when you're checking their urine. Hot sitz baths. I haven't had a lot of success with telling patients to take hot sitz baths to relieve their symptoms, but it is something you can do. I don't know who has a bucket like this at home. I don't know if you pot plants or something and it doesn't have a hole in the bottom of it, go for it. Most of the time, if you're recommending that somebody do sitz baths, it's usually just putting a little bit of water in the bottom of the tub rather than having them sit in a planter. All right, so complicated cystitis. Same drugs, longer duration. And potentially intervention, depending on what the underlying cause of their complicated cystitis is. And you're definitely more likely to utilize fluoroquinolones for these patients. All right, recurrent cystitis. 2 or more infections in a 6-month period, or 3 or more in a 12-month period. Culture proven. If they've been getting empiric treatment at the urgent care over and over and over again, and the urgent care never sent a culture, they don't have recurrent cystitis. It hasn't been proven yet, because there's so many other things that can cause those symptoms. I can't tell you how many times I've seen somebody who's been referred to us for recurrent urinary tract infections and they had OAB. And they've just been getting antibiotics for no reason. If they have recurrent urinary tract infections, culture proven, send them to urology. Send them to us. We're not really the bladder infection doctors, but the patients end up coming to us anyway because often they have structural abnormalities that do need to be addressed. Don't send a patient who's had their first urinary tract infection ever to us unless they're male. Because like I said, we're not UTI doctors. And then patient education, always very important. So hygiene, wiping front to back, staying well hydrated, postcoital voiding habits. So urinating immediately after intercourse can help reduce the incidence of postcoital urinary tract infections. All right, so prophylaxis. So if you're going to put somebody on prophylaxis, obviously they need to not be allergic to it, whatever it is you're thinking about giving them. And it needs to not be a big gun, broad spectrum antibiotic that we want to keep in reserve to treat those hard infections, right? So macrobid is a very, very common agent used for prophylaxis. You can't give it to somebody who has a sulfa allergy, so just like Bactrim, you can't use nitrofurantoin in somebody with a sulfa allergy. And I think we talked about this before, but what's another potential side effect of macrobid that you need to be cautious with if you're gonna put somebody on chronic prophylaxis? It's pulmonary. So one of the very rare but very bad side effects that you can get from macrobid is pulmonary fibrosis. Pulmonary fibrosis don't get better once it happens. So technically, if you're gonna put somebody on chronic nitrofurantoin prophylaxis, you should send them for PFTs first to get a baseline. Most people don't do that, but you should. And then if they start developing pulmonary complaints after they've been on it, definitely send them to pulmonology and get some PFTs and make sure they're not developing pulmonary fibrosis. I've seen this one time, but it does happen. Keflex is always a good choice, very well tolerated. Even people with penicillin allergies usually don't have crossover into the cephalosporins. And then, as you can see with fosfomycin, if you're going to use that for prophylaxis, it's only once every 10 days as opposed to nightly. And then if it's postcoital, you just have them take it before they have sex, or immediately following. It doesn't necessarily have to be before. Hold on, I got to take my antibiotics. A little bit of damper, a bit of a damper on things. After is fine, as long as it's immediately following. You don't want to delay it, like the next morning is too late. So either immediately before or immediately after. Any questions on this? All right, let's get through this slide and we'll take a 10-minute break. So, prevention, hydrate, urinate frequently. Everything you can do to flush the urethra out helps reduce the risk of urinary tract infections. And then, as we talked about before, after intercourse, void before and after, and then postcoital single dose of antibiotic if they're, or precoital, either way, if they are prone to having urinary tract infections after intercourse. And then postmenopausal women can develop atrophic vaginitis, which you may have heard about in dermatology. You will definitely hear about it in women's health. So with the loss of estrogen production, the tissues of the vagina and the periurethral tissue start to thin out, and normal vaginal secretions taper off. They just don't produce as much anymore. And as a result, that tissue becomes much more friable, much more delicate, and they lose what little natural protection that they had. So atrophic vaginitis can also cause symptoms that mimic a urinary tract infection. They can have dysuria, urgency, frequency, another reason to get a culture. And the way you treat it is with topical estrogen. Now, people always get anxious about giving estrogen replacement to older women, particularly if they have a history of breast cancer, uterine cancer, things of that nature. But when you're using it for topical treatment of irritative voiding symptoms or to help prevent urinary tract infections, we actually collaborated with the uro-oncologists, gyn-onc, good Lord, I'm not even talking straight today. The gyn-onc folks at BAMC when I was on staff there, and talked to them about the way that we recommend using topical estrogen for this specific purpose. So you may or may not be aware that you can use estrogen cream transvaginally for systemic estrogen replacement therapy. And to do that, there's an applicator that's similar to a tampon that you fill with the cream, and then the whole cream dose is delivered into the vagina. That's not what we do for this. We use the same cream, but instead of giving the whole dose intravaginally, you have the patient put like a pea-sized amount on the tip of a finger, and they just apply it directly around the urethral meatus. And just doing that local treatment helps the tissues thicken up, reduces the irritative voiding symptoms that they might have at baseline, and helps prevent them from getting urinary tract infections. So something to think about in your postmenopausal life. All right, let's take a 10-minute break. Remember, it's uncommon in men. If you see a guy with a urinary tract infection, send him to urology. They might have BPH. They might just need a circumcision. They might need both taken care of. And then uncircumcised men have an increased risk of urinary tract infection over circumcised men. And then always get a comprehensive sexual history. Even if it's not the most pleasant thing to do, even if it's kind of embarrassing, even if you're talking to someone who's old enough to be your grandmother or your grandfather, ask. So this is another thing I brought up with my ClinCore small group. What two populations have the highest increase in the rate of sexually transmitted illnesses right now?
Old.
The elderly and
Young people.
the younger, right? So the people in the middle, not so much of a problem. I mean, the incidence is about the same, but we're definitely seeing an increase on the younger side, and we're really seeing an increase in the geriatric population because they're widows and widowers, and they're living in a retirement community with other people who are widows and widowers, and they're just living life, just enjoying the time they have, and they're all getting syphilis. I wish that was a joke. It's not. The syphilis rates in the geriatric population are really high right now. So get a sexual history. It's important. All right, so pyelonephritis. Do these look like healthy kidneys?
No.
No, for a couple of reasons, right? They look all goopy, and some of this may be perinephric fat that's still stuck to the specimen, but also they're not inside anybody anymore. So these are definitely not healthy kidneys. So pyelonephritis, not to beat a dead horse, right? So usually an ascending infection, can be hematogenious. Hallmark is flank pain and fever. Okay? And then you may see white cell casts on microscopy. Most commonly, it's going to be your same gram-negative bacteria that cause urinary tract infections. Obviously, Pseudomonas is one you're more likely to see in a nosocomial setting. And then sometimes you'll see gram-positive bacteria. But most of the time, it's going to be these. Fever or high fever. If they're really, really, really sick, fever of 103, 104, I've seen 105, consider imaging. But otherwise, I mean, if they got a temperature of 101 and they got flank pain and dirty urine, they got pyelo, treat them. They may or may not have irritative voiding symptoms. If it's an ascending infection that started in the bladder that never got treated, then they may still have irritative voiding symptoms. If it happens to be pyelo that originated from a hematogenious source, they may not have irritative voiding symptoms because the problem's up here and nothing's going on down in the bladder. Okay? They can be extremely tachycardic. They can be hypotensive. They can have shaking chills, nausea and vomiting, diarrhea. Diarrhea less common. But I mean, they can be really sick. Pyelonephritis can be fatal. Urinalysis, your microscopy is going to be the same as for a regular old UTI, except that you're likely to see white cell casts. On a CBC, do you think you're going to see a leukocytosis in somebody with a simple UTI? You shouldn't. If you see a leukocytosis, look for something else. But in pyelo, they're definitely going to have an elevated white count with a left shift. Always check a urine culture. And then for pyelo patients, check a blood culture too. Because one, it might have come from a hematologic source anyway. And two, even if it's an ascending infection, they can still develop bacteremia. So check a blood culture. And also the whole thing with ticks and fleas, right? They could have more than one organism at play. CT scan, consider in patients with risk factors or if they're not responding to antibiotics or if they're just on death's doorstep at presentation, then get a look at things on the inside and make sure that they don't have a big renal abscess. This is a kidney. This is a kidney. What looks different between those two kidneys? So I'll tell you it is a contrasted CT.
One has more contrast.
So what you see here is contrast,
Is it?
okay, not stones. But look at the parenchyma. What looks different from one side to the other?
Contrast is infused in there.
So the hint is the giant red arrow. So you see how the parenchyma on the right kidney has sort of this striated pattern? There's not really a pathognomonic appearance to pyelonephritis on imaging. It just doesn't look right, and especially when you compare it to the other kidney. So you notice that there's a difference here. So if this patient came in saying, I've got right flank pain, and I've got a fever, and my urine's dirty, and you do imaging, this is what pyelonephritis can look like. So your differential includes lots of other intra-abdominal processes, right? So appendicitis, cholecystitis, pancreatitis, diverticulitis, all them itises can be in your differential when you're talking about pyelo. Why would epididymitis be on the differential for pyelo? In what world does that make sense? I promise you it does.
During sex?
Louder?
During sex? You could,
So we're talking differential, right? We're talking about why would you think about epididymitis in a patient who actually has pyelo? So we're not saying that they might have pyelo and epididymitis. Consider epididymitis when somebody has symptoms that are pyelo type symptoms. So the reason that it needs to be in your differential is because they can present, epididymitis can present with flank pain because of nerves, right? So the testicles form in the abdomen, right next to the kidneys, and then they descend. And so the nerve roots all end up in the same place. So somebody who has something going on down here might have symptoms up here. That's why epididymitis is potentially in your differential when somebody comes in complaining of flank pain and fever. And then, you know, you look under the hood and see they've got a giant swollen testicle, and that takes care of that. And then PID. And occasionally acute cystitis will present with flank pain as well when they don't actually have pyelonephritis going on yet. Most people recover kidney function after pyelonephritis. Now, if you got somebody who has a solitary kidney and it takes a bad hit, then they may not recover all of their pre-illness renal function. And if they're already old and frail, or have just been sick for a long time with chronic kidney disease already, then they can take a hit, even if it's, you know, we're just talking unilateral pyelo. And then, as I mentioned several times before, if they're not responding to therapy, think about a renal abscess, and you diagnose that with imaging. If you find a renal abscess, the people who normally take care of renal abscesses are interventional radiology, because they'll stick a drain in it percutaneously. We generally, in urology, don't deal with renal abscesses directly. And then emphysematous pyelonephritis. So this is really bad. Emphysematous pyelonephritis is basically like neck fash of the kidneys. Okay, so you got gas-producing organisms. Typically, it's going to be in a diabetic or some otherwise immunocompromised patient. So if you get that CT scan because they're not getting better, or they came in really, really sick at baseline, and they've got gas in the parenchyma of the kidney, that is emphysematous pyelonephritis. If they have gas-forming organisms in their urine, in the renal pelvis, and there's air fluid levels in the collecting system, not in the meat of the kidney, that is emphysematous pyelitis. It is not as bad. It's still bad, but it's not like neck fash of the kidney, Okay, if there's gas in the tissue, bad problem. Often those patients end up getting nephrectomies because antibiotics isn't enough to clear it. So here you go. Gas in the kidney, in the meat, not in the collecting system. This is a pretty significant case. One, it's bilateral, and two, even if it wasn't bilateral, even if it was just one side or the other, this is bad. This person's probably headed towards a bilateral nephrectomy. Outpatient treatment is often appropriate for patients with pyelonephritis as long as they're not on death's doorstep or pregnant. If they're pregnant, you want to treat them as an inpatient. If they're non-compliant, you want to treat them as an inpatient. But if they're reliable and not pregnant, then you can treat them as an outpatient. But you want to see them back within 72 hours. Make sure that they're responding appropriately to therapy. If they're still just as sick as they were on day 3 as they were on day 0, then you might need to admit them for IV antibiotics or get imaging, or both. But if you are going to treat them as an outpatient, obviously the antibiotics go without saying, but then give them something for pain. Pyelonephritis can be very, very uncomfortable. And if they've got nausea and vomiting, give them some antiemetics. Follow them up closely. And these are the patients that you're likely going to start with a fluoroquinolone. Because one of the great things about fluoroquinolones is that the tissue penetrance of fluoroquinolones is the same between PO and IV. Not every antibiotic can say that. Some antibiotics are more effective from a tissue penetrance standpoint if you give it IV. But with the fluoroquinolones, it's identical. It is the same. You get the same effect. So you're basically giving somebody a potentially outpatient treatment, or excuse me, a potentially inpatient treatment as an outpatient. So yeah, if they've got pyelo, consider fluoroquinolone as your first line. Obviously, don't give them a fluoroquinolone if they're pregnant or if they're allergic. So, if the community prevalence of fluoroquinolone resistance is unknown, so you don't know, or if it's known to be greater than 10%, greater than 10%, remember this slide, long-acting parenteral agents first, ceftriaxone being your #1 go-to. Ertapenem, you're going to have to get ID on board to get some ertapenem. They keep that behind a locked door. Your carbapenem antibiotics, they don't let anybody prescribe those without ID signing off, because it's one of the last remaining big guns that we have that's good broad spectrum and treats a lot of otherwise multi-drug resistant organisms. Obviously, gentamicin is a little bit nephrotoxic, so you got to be careful with that. And then add on top of it an oral fluoroquinolone. That's if you don't know the E. coli resistance, or if it's known to be 10%. Give them double therapy. And I mean, like I said about the ertapenem, yes, this is true, but don't count on being able to get ertapenem for a one-time dose in any military treatment facility. The ID is going to stomp on that real fast. Nobody says nobody bats an eyelash to Rocephin. Give it ceftriaxone. Alternative agents, if they can't have a fluoroquinolone, all the same ones as before, with Bactrim or Augmentin or cefpodoxime, which is Vantin, Cefdinir, Ceftrexil. Some of these are things that you would normally associate with treating pediatric infections, but for this application, they work just as well. And then, as we've already said, admission, inpatient treatment, if they're not reliable, if they're pregnant, if they're really, really sick, looking septic, if they need imaging. So if they've come back, they didn't get better, image them. Diabetics, renal failure, if you find that they have a multi-drug resistant pathogen, like you tried to treat them as an outpatient, you get your culture results back, multi-drug resistant organism that requires IV medication, admit them. Uncontrolled symptoms, and if they have any sort of obstructive uropathy. So that means BPH, keeping them from emptying well, that might be the inciting event that caused them to get pyelo. If they have pyelo and a stone, and when I say and a stone, I don't mean they've got a non-obstructing stone just hanging out up in their collecting system, not doing anything. I mean if they have pyelo and a stone in the ureter, that is a surgical emergency. People can die quick with obstructive pyelonephritis. So if you see somebody who's got dirty urine and a fever and a ureteral stone, call urology. This is one of the things we come in for in the middle of the night. It's a short list. That's one of them. The key thing on this slide is after 48 hours of an inpatient treatment session, you can switch to oral therapy as long as they've been improving, and provided that you have an oral agent that is appropriate, that the bacteria is susceptible to. And then you watch them and make sure they don't spike another fever after you switch to oral medication, and then you can let them go home and then treat for 14 days. Said this a bunch of times already. If they're still sick, get a CT. And you must get a follow-up urine culture. You got to make sure you wipe it out, because if they're still throwing off bacteria after 14 days of antibiotics, if you don't eradicate everything they've got going on, what do you think the chances are that's going to turn into a multi-drug resistant organism, or at least resistant to what you've been giving them? Make sure you've wiped it out. Okay, urethritis. Gonococcal, most common. Non-gonococcal, chlamydia is going to be the most common one there. Trichomonas, you can have herpes urethritis. It is possible to have herpes lesions develop in the urethra. Most cases of urethritis are sexually transmitted. Not always, but mostly. Urethritis can also be caused by atypical organisms. So remember, we were talking about, is urine sterile? Kinda. Normal urine doesn't grow any of the major pathologic organisms, but if you were to culture for some oddball things, you might still find positive growth in urine that otherwise looks clean. If you have somebody who's complaining of urethritis type symptoms, so discharge, pain, dysuria, and you've cultured them, and you've checked the GC and chlamydia, and you checked them for herpes, and you've covered all your bases, and they're still having these symptoms, they may have one of those atypical organisms. Give them a course of Flagyl. You may never know what the organism was that was causing their symptoms, but if they have atypical urethritis, give them a course of Flagyl, metronidazole, and you may make them the happiest person alive and become their most favorite person because you fixed their burning urethra. But the preponderance of cases are sexually transmitted. Patients typically young and sexually active, or old and sexually active. The discharge can be mucoid, it can be purulent, it can be clear. It can be absent. There might not even be any urethral discharge. But your mucopurulent discharge, think gonorrhea. Clear discharge, especially from a male patient, think chlamydia. Always check for both. And if you have a high suspicion, always just treat empirically. And again, up to 40% of these patients may be asymptomatic. They may not even know. You're going to see when you get to your ER rotation that you're checking GC chlamydia on everybody for any particular reason, because they might have it. This is what it looks like. So penile discharge, that's a cervix right there. Cervical mucopurulent discharge. And then it's kind of hard to see on the far right picture, but that's clearer discharge. That's more like what you'll see with chlamydia. Sexual history, get it. If you feel like the patient's holding something back, they probably are. Try to get it out of them gently. check your nucleic acid amplification test. Great thing is now we can mostly do this with urine. When I started my training, you had to swab people's urethras. Getting them to consent to that was challenging. They didn't want anything shoved in their urethras. And always remember to check for the other sexually transmitted infections. Ticks and fleas. If they've got one, they probably have another. RPR is for what? Syphilis. Incidence is going up. Check an RPR. Hepatitis panels, HIV, herpes swab if lesions are present. If they're not, you can't swab it. So. All right. Same organisms, right? Chlamydia, gonorrhea, occasionally HSV. Internal dysuria. So it's going to be bladder pain as opposed to urethral pain. So in males, it's like, I feel like I'm pissing razor blades. It's a common complaint. You'll hear that a lot. Or broken glass or something along those lines. But the point is, it's urethral pain. And in women, it may be more of a bladder pain type presentation, unless it's an external process like candidiasis or vulvar herpes. Then it'll be more of an external discomfort. Same symptoms: urinary urgency, frequency, hematuria, bladder tenderness. All of those things suggest bacterial cystitis, but you have to think about these sexually transmitted organisms as well, because it could be internal dysuria. CDC recommends treating chlamydia with doxy, gonorrhea with ceftriaxone, so you're just going to give everybody both. If they test positive for one and not the other, you're still going to treat them for both. Everybody gets an IM dose of Herceptin and then oral doxy to go home with. And then tell your patients to avoid sexual contact for 7 days after completing the antibiotic treatment and resolution of their symptoms. So even after that, 7 days after symptoms have resolved and they're done with their meds, they need to abstain. And of course, treat sexual partners too. Okay. Contact tracing. Fortunately for us, virtually every military treatment facility has an occupational health clinic, which usually has at least one public health nurse. I had a whole public health nursing clinic when I was at Fort Belvoir, and they would be funneled all of the reportable infections that were discovered in the lab. So anybody who had anything tested for, whether it was a sexually transmitted illness or something else that was a public health concern, the results would get funneled to the public health nursing clinic, and we had epidemiology techs who were responsible for calling the patient and doing that contact tracing. Might you find yourself in a situation where you have to do contact tracing on your own? Yeah, you might. So know that it's a thing. Know that it exists. We did a lot of contact tracing during COVID, but as it pertains to sexually transmitted infections, usually the only person you're going to be responsible for contacting is the patient. But just know that you might find yourself in a situation where you're also needing to contact partner or partners. All right, so we talked about vesicoureteral reflux. These are the grades of vesicoureteral reflux. So grade 1 is on imaging, you can see urine going back up towards the kidney. So you put contrast in the bladder through a catheter and have the kid urinate under fluoroscopy, and you'll actually see contrast reflux, but there's no structural change, all the way up to grade 5, where they've got massive hydroureteronephrosis all the way down to the bladder. Okay. If you have a fever in an infant or a young child, always consider UTI as part of your differential, because kids can get fevers with urinary tract infections even if it's just in the bladder. Also, they might have VUR that hasn't been diagnosed yet, because this is how we find out they've got it. If it wasn't discovered on a prenatal ultrasound, because sometimes if they have really bad VUR, you can actually see big blown out fetal kidney on transabdominal prenatal ultrasound. But if they didn't have that, And now you've got a relatively young child, newborn, or, within, a year or two of age, and they have a fever, and you haven't explained the origin yet, check them for UTI, and then send them to urology, because they may have vesicoureteral reflux. Dysuria plus fever, pyelo. Can I make this any more obvious? All right, so that's it for infections. The interstitial cystitis talk is really short, so let me get that pulled up, and we will get that done. Any questions about UTIs, pyelo, reflux, any of that? Okay, interstitial cystitis. Here's your learning objectives. Here's the definition. The bottom line for interstitial cystitis, it is a diagnosis of exclusion. What does that mean?
Rule everything out first.
You gotta rule out everything else first because there's not a test for it, okay? There's no test for interstitial cystitis. You gotta rule out everything else first, and then what you're left with is interstitial cystitis, okay? So an unpleasant sensation, pain, pressure, discomfort, perceived to be related to the urinary bladder, associated with lower urinary tract symptoms of more than 6 weeks duration in the absence of infection or other identifiable causes. The hallmark symptom of interstitial cystitis is bladder pain with filling. So as they get more full, and I'm not talking over full, obviously it hurts if you need to go to the bathroom and you're not near a toilet and you're trying to hold it as best you can. We're just talking about normal bladder filling. As their bladder starts to fill, they start developing more bladder pain and pressure, and it's relieved with urination. Bladder pain, worsening with filling, relieved with urination is your hallmark sign of interstitial cystitis. The precise etiology and pathophysiology is uncertain. Remember, just a little while ago, we talked about that glycosaminoglycan layer of the bladder. There's some people that think if that glycosaminoglycan layer starts to become permeable for some reason, just the presence of normal urine starts to irritate the underlying layers of the bladder and results in interstitial cystitis. But we don't know. We do know it's more common in women by a 10-to-1 ratio, and mean age of onset is 40. And it's often associated with these other very pleasant conditions. Irritable bowel syndrome, irritable bowel disease, fibromyalgia. Really, interstitial cystitis is kind of the fibromyalgia of the bladder. This is the fibromyalgia of the urology world. It's irritating for the patients, it's irritating for the people trying to take care of them. Chronic fatigue syndrome, depression, anxiety, other chronic pain syndromes, all of these things are associated with or potential comorbidities of interstitial cystitis. Diagnosis of exclusion. So you do need to get these things. Don't get a cytology. Send them to us. If we think they need a cytology, we'll get the cytology. But there's your textbook answer, okay? And again, just to hammer home the don't get the cytology thing, what happens if you check a cytology because you're working somebody up for interstitial cystitis and it comes back with atypia? What are you going to do with that?
Send them to you.
It's not specific. It doesn't. It's not normal, but I don't know what it means. Now the patient's freaking out. Now you're freaking out.
I need an adult.
You're going to send them to us anyway. Just don't get the cytology. If we think a cytology is necessary, we'll get one. But definitely get a urinalysis and culture for sure. Again, disruption of the glycosaminoglycan layer allows irritants to irritate the underlying nerves and muscle tissue, and then it causes progressive irritation and inflammation. Again, we don't know if this is true. This is a theory. Here's a diagram of the theory. All these things might happen, resulting in a bladder insult, which causes these things to happen: mast cell activation, histamine release, urothelial permeability changes, progressive injury. Okay? Again, we don't know. You will not see this diagram on the test. Now, what things you can see in patients with interstitial cystitis is glomerulations and Hunner's ulcers. These are things that we're gonna see when we do a cystoscopy on them after we're, gone through the process of ruling other things out. The glomerulations are not necessarily seen just at baseline. Like, we might not put a scope in somebody and say, oh, there's glomerulations here. The glomerulations are normally seen after we do hydrodistension, which is something that's still done to this day to treat interstitial cystitis. Why does stretching the bladder out further than it's supposed to be with water under pressure make their symptoms better? I don't know, but it works. So we still do it. But one of the ways that you know that you've done enough hydrodistension is they'll develop these glomerulations, assuming they have interstitial cystitis. The Hunner's ulcers are much more pathognomonic for interstitial cystitis. And I think I have a slide later on that actually has a photograph of one. But again, remember, it's a heterogeneous clinical syndrome. Everything else has to be ruled out before you can make a diagnosis. And their symptoms may be bladder-centric. It may be the whole pelvic floor. So they might have bladder pain. They might have pain with defecation, just generalized pelvic pain. They can have widespread chronic pain. Again, we see this in people with fibromyalgia. It may be psychosocial in origin, and it may be polysymptomatic. So if you've got a patient that you're already seeing who you know has chronic pain syndrome, fibromyalgia, anxiety, depression, and now they're complaining of urinary tract issues, symptoms, rule out all the things that you can rule out, and then you might be dealing with somebody with interstitial cystitis as well. Pain relieved with urination. Remember that. Pain relieved with urination. And again, general pelvic pain. And not everyone's going to say pain. They may use other words to describe their symptoms. Just keep that in mind. Pain doesn't always mean the same thing to everybody. Certain foods and drinks can trigger symptoms. This also applies to people with overactive bladder. So anything that's high in vitamin C, caffeine. So who here thinks caffeine's a diuretic? Raise your hand. Is caffeine a diuretic? I got a couple hands. Caffeine is not a diuretic. Caffeine makes you feel like you need to go to the bathroom when you've consumed it, because when your body metabolizes caffeine, the methylxanthine metabolites of caffeine that come out in the urine have a very, very similar chemical structure to acetylcholine, which is the main neurotransmitter in the sensory nerve endings of the bladder. And so you put caffeine metabolites on those nerve endings, and the end result is, I gotta go to the bathroom really bad. But your bladder may not necessarily be full. Put it to the test. Drink something that has caffeine in it, but of a relatively low volume, so like a 6-ounce cup of coffee, or the first part of your early morning White Monster. Don't drink the whole can, and just wait and see how long it takes before it feels like you have to go to the bathroom, and then go and see how much comes out. The sensation is probably going to be disproportional to the amount of urine that you produced. So caffeine, since you know that it can cause a sensation of urinary urgency, or at least bladder filling in a physiologically normal person, what do you think it does to somebody with OAB or interstitial cystitis? They gotta go, or it hurts really bad, one or the other. So caffeine, vitamin C, spicy foods do it to some people. It doesn't happen to everybody, but sometimes people are actually sensitive to the capsaicin metabolites that come out of urine, and it presents as either dysuria or a sensation of urinary urgency and frequency. Worse in people with interstitial cystitis. They often also have sexual dysfunction in the form of dyspareunia, so it's painful for them to have intercourse. know that the symptoms have to be continuous for 6 weeks with negative urine cultures. That's the first step towards making a diagnosis. Rule out everything else and then negative urine cultures with symptoms for 6 weeks. Again, there's overlap here between OAB and interstitial cystitis or bladder pain syndrome. They both can have urgency, they both can have frequency. OAB can have urgent incontinence, but OAB generally doesn't have pain. Pain is usually associated with interstitial cystitis or bladder pain syndrome. As part of your process of ruling out everything else, you're gonna do a pelvic exam, or we're gonna do a pelvic exam. Somebody's gonna do a pelvic exam. If they're male, yes, men can have interstitial cystitis too, it's just significantly less common. We'll do a prostate exam, or you'll do a prostate exam. Somebody will do a prostate exam. And then they're also gonna get a cystoscopy by the time they make it to us. Any questions on any of that? Things that you can do as adjuncts to making diagnosis. You can do avoiding diary. Who knows what avoiding diary is? Or can describe it?
Making notes of your urine when you go and what it feels like.
Yeah, so avoiding diary is literally just that. You ask the patient to keep track of every time they urinate for a set period, usually 3 to 4 days. So you want to know what time, how much. So you're going to give them a urinal or a toilet hat. Oftentimes they're just going to do their avoiding diary over a weekend so that they're not carrying their toilet hat to the mall or to work. And other associated symptoms. So was your urination associated with a sudden urge? Did you leak, yes or no? And they also have them keep track of their fluid intake. So every time they drink anything, they write down what it was and what the volume was and what time. And they put all that information on, there's pre-printed forms for it. If you don't have access to that, you can just have them do it on a piece of paper. And that can tell you a lot about a person's voiding habits. There are also these other validated questionnaires, the GUPI, the ICSI, the Interstitial Cystitis Problem Index, that you can use for patients that you suspect have interstitial cystitis. The voiding diary is good for interstitial cystitis, and it's also great for any other voiding complaints. So if you're evaluating somebody for stress incontinence, urge incontinence, mixed incontinence, give them a voiding diary. Here's what those questionnaires look like. Okay. So, cystoscopy, urologists do cystoscopy, not nephrologists.
Yeah, yeah.
Just to beat that horse to death. Only urologists do cystoscopies. Nobody else does cystoscopies, just us. And as we've talked about before, it can be used to identify bladder tumors, stones, urethral diverticula, anything in the bladder that's a foreign body. But specifically, as we're talking about interstitial cystitis, we're looking for Hunter's ulcers. So these are glomerulations up here. So this is what it looks like after you've hydrodistended somebody. These pinpoint hemorrhages. And then Hunter's ulcers. So that's the center of the ulcer, right there. So there's one right there. This patient actually looks like they've had treatment in the past for their interstitial cystitis, because this white band that you see here in the middle, that's a scar. That's what scar looks like on the inside of the bladder. So, but that's an ulcer, that's an ulcer, that's an ulcer. There, okay. Differential diagnosis, you gotta rule out everything, right? So, cystitis, all those sorts, vaginitis, endometriosis, genital herpes, all these things can cause symptoms that are similar to interstitial cystitis. Bladder cancer, urethral diverticulum. When you get down to this point, it's urology is going to be ruling those things out. No cure. Hooray, what every patient wants to hear, right? No cure. So the aim is symptomatic relief. I already mentioned that we can do bladder distension under anesthesia. So we take them to the operating room, put them to sleep, put a rigid cystoscope in their bladder, hang a 4-liter bag of saline and put it on an IV pole and elevate it to the ceiling. So we don't put it in with an IV pump. We don't pump fluid into the bladder. It's done under gravity, but we raise it really high off the ground so we can get more pressure. And we let the bladder distend until nothing will drip in anymore, and then we drain it. And we might do that twice. And oftentimes that provides some symptomatic relief. There are medications that we can use in the form of bladder installations. Some people still do lidocaine and heparin mixed together as a bladder installation for interstitial cystitis. It's off-label. There's no FDA indication for it, but it's something that's done. There's also a chemical called DMSO. This is not on the test, but DMSO for a long time was like the mainstay of intravesical therapy for interstitial cystitis, and it would be done in a urologist clinic. We'd put a catheter in the bladder, instill the DMSO, take the catheter out, have them hold it for a while, and then urinate it out. Most of the time what we do now is behavioral and then oral medications. And when it says major surgery, we're talking about taking their bladder out, doing a simple cystectomy. That is a measure of last resort, because you gotta rebuild their urinary tract if you take their bladder out. And what do you think the likelihood is that their symptoms of pelvic pain go away after you take out their bladder? Not great. Some people it helps, but you have to counsel them extensively and say, hey, you may not get better after we take your bladder out. You may still have the same symptoms. So more often than not, it's behavioral modification, oral medications, and trying to help them learn to live with it. So diet, we already talked about, needing to modify their diet. Sometimes people get relief from heat and cold packs. Occasionally, you can get some relief for them using percutaneous tibial nerve stimulation, so TINS units. And then acupuncture, exercise, biofeedback, massage, pelvic floor PT. Who knew that there was such a thing as pelvic floor physical therapy? It exists. It's a thing. Yep. So it's often done in postpartum situations. It's done to help treat stress urinary incontinence, overactive bladder, and it can provide some relief in chronic pelvic pain type situations like interstitial cystitis. Psychosocial functioning, quality of life, all these things are adversely affected by interstitial cystitis, and it becomes a vicious cycle. They can't do the things they want to do, they're uncomfortable all the time, causes depression and anxiety, which makes their symptoms worse, and it just keeps getting worse and worse and worse until you break the cycle. So referral to behavioral health should be strongly considered in patients with suspected interstitial cystitis. Now, of all these medications, only one of them is FDA approved for treating interstitial cystitis, Elmiron, pentosan polysulfate. Remember that. You might see that again. Okay? Not really sure why it works, just like we don't know exactly what causes interstitial cystitis, but it is the only FDA approved medication for treating interstitial cystitis. It's believed to coat the bladder, act as an analgesic, and help restore that glycosamine and glycan layer. Okay. But other things that have been used in the past, because we do know that there's a behavioral health component to it, amitriptyline, hydroxyzine, cimetidine. Questions? And then here's those intravesical installations I was talking about before. Lidocaine and heparin, DMSO. Hydrodistension. And if we're doing hydrodistension and they have Hunter's ulcers, oftentimes we'll also cauterize the ulcers. We don't do anything to the glomerulations, but the ulcers will fulgurate, and oftentimes that helps provide some symptomatic relief as well. And intravesical Botox is used for OAB, but as an off-label use, some people also use it to treat interstitial cystitis symptoms with mixed results. And then last resort, so these neuromodulation devices, InterStim is the main one. It's made by Medtronic. It's most often used for overactive bladder. It can also be used to treat people who have underactive bladder from something like, say, multiple sclerosis. Mixed results when it comes to interstitial cystitis, and then your cystoplasty, which is to make the bladder bigger, versus a cystectomy, which is to take the bladder out. It's very challenging. Be patient. The patients will be anxious, they'll be frustrated, you'll be frustrated, the things that you try to do to take care of them. Their symptoms are real. They're gonna be like your typical behavioral health fibromyalgia patient. Nothing makes them better, they're depressed and anxious all the time, and it can be very frustrating and taxing for you as the provider. Be patient. And from your perspective, send them to urology as fast as you can, because then they won't be your problem anymore. But work them up, make sure they don't have something else going on, and then you guys can lay the groundwork for realistic expectations at your level before you end up referring them on for specialist care. They need to know that it's probably going to require multiple treatments. It's going to be a multimodal approach. They may not have a lot of improvement. They're going to have to live with it for their entire life, more than likely. And there's no cure. In case you're interested, this is the link to the Interstitial Cystitis and Bladder Pain Syndrome guidelines from the American Urological Association. If you can't fall asleep and you need something to knock you out, go ahead and take a look at that. Any questions about interstitial cystitis? All right. That's it for today.